All right, here we go. This is the second half of the endocrine chapter, and this will be the last of the material. What we covered today, I'm sure we'll finish endocrine. Will be the last of what's covered on this test next Thursday. So what that means is that Tuesday, I'll start lecturing on the heart, but it won't be covered on this test. Does that make sense? Okay. Okay, I think that this graph right here, this diagram right here, is really important, and I think you ought to basically almost be able to draw it because there's nothing on there that's really very hard. Let me show you what I mean by that. So, this is a diagram that kind of summarizes the endocrine system, and I think we talked about this a little bit before, but just remember that the anterior pituitary gland, illustrated by this front part of it here, it gets its input from the hypothalamus, basically, and the hypothalamus sends releasing factors down to the anterior hypothalamus through that little portal system that we talked about yesterday, capillaries to concentrate, so all those little releasing hormones get sent down straight from the hypothalamus to here without being terribly diluted. So you get enough of them here. The releasing factor, the ACTH releasing factor, comes from up here, comes down to here, and then causes the ACTH, adrenocorticotropic hormone, to be released by the pituitary, the anterior pituitary. ACTH circulates around in the bloodstream, and it acts at the suprarenal cortex to control the adrenal cortical hormones that are made there in the adrenal cortex. Now I noticed that Melissa is calling the three parts of the adrenal gland salt, sugar, and sex. Okay, that's the three main groups of hormones that are released by the adrenal cortex, and that's a good way to help you remember it. Okay, so this thing secretes the outside, the cortex secretes the glucocorticoids, cortisol, and things like that then go around the body and affect the things that need to be affected by them. Notice that the medulla, the middle portion of the adrenal gland, receives direct neural input. Direct nerves are controlling it from the hypothalamus, but that's a nerve thing. It's not done by hormones. That's what this red line means. It goes down here and causes the medulla to release epinephrine and norepinephrine, and that's a real sudden thing, and that is the old fight or flight thing, right? So when you get this, you got the tiger walking in the room, that signal comes not only this way and goes through ACTH, but that's a slower system. It actually sends a signal down through nerve pathways directly to the adrenal medulla, releases epinephrine, norepinephrine, and you're jazzed up and you're ready to fight or flight. TSH, thyroid stimulating hormone, it doesn't have any nerves going to the thyroid gland. It's simply releasing factors are made up here in the hypothalamus. They're passed down through that portal system. They're called thyroid releasing hormone. Okay, so and thyroid releasing factor. It comes down here. It causes the release of TSH, thyroid stimulating hormone. That is the hormone that's released by the anterior pituitary, circulates around through the blood, goes to the thyroid gland, and then the thyroid under the auspices of the TSH, releases thyroid hormone out into the body. Okay? Now, what feeds back to turn it off? Thyroid hormone, T3 and T4. We'll learn more about them in a few minutes. Okay. All the rest of these pretty much work the same way as TSH. Here's growth hormone. Somatostatin works on the bones and muscles. You've got prolactin, PRL, works on the breasts. FSH and LH are releasing factors, come down, cause those things to be released. The FSH and the LH then go to the testes and the ovaries and cause the follicles to be stimulated. We'll go into that much more depth when we get to reproductive. Then from the pars intermedia here, the one in between, it releases MSH, melanocyte stimulating hormone, which then goes to the melanocytes. Remember, the melanocytes are out in the skin. Remember them? And then they make more melanin. What does that say? What? Oxytocin. I'm sorry. I have to tell you, if you guys were standing up here where I'm standing, it just looks like a bunch of dots. Oxytocin, which is one of the two hormones. Remember, there's only two hormones released from the posterior pituitary, and they are not actually made in the posterior pituitary. The hormones aren't made there like these guys were in the anterior. Remember, the posterior pituitary, when you look at it under the microscope, it doesn't look like glandular tissue. It looks like nerves. It looks like a bunch of white matter, right? And the deal here is that these two hormones, the ADH and oxytocin, are both actually manufactured in these nerves up here in the hypothalamus. And they travel down through the axons of these direct connecting nerves down into the posterior hypothalamus, and then they're released from there. So they're not actually made there, they're simply released there. And they travel through the axons to get down there. Question?
Because they're traveling down axons, are they actually considered, are they hormones at that point? Or
yes.
Are they neurotransmitters and then?
Well, they're not really they're not moving along at the speed of electrical impulses. They're just, it's axonal flow, basically, the flow of the materials through the axon. All right. So, be sure you look this over. Be sure you understand it. This slide right here is a pretty good answer for one of the essay questions, which is the pituitary gland is called the master gland. Why is it called the master gland? Oh, there you got a pretty good answer right there, or at least most of it. Oh, please, little thing, please work. Well, the hypothalamus is the part of the brain that controls the pituitary, which is really the gland. Okay? And remember, we've talked about a number of times as we've gone through the hypothalamus, is that the hypothalamus and the pituitary are the places where the two control systems of the body kind of interact with each other. Neural system and endocrine system. Okay. I'll get rid of that. This is a CAT scan I found once upon a time of a little microadenoma, a little tumor growing here in the pituitary gland, and I think I'll just leave it at that. Today, with modern imaging techniques, with CT scans and with MRIs, you can see things that are, a millimeter in size. It's just fantastic. Let's talk about the thyroid gland. Okay. You ever known anybody who was hyper? When you say, that Brian Patrick guy, he's really hyper. What does that mean to you? Kyle, what does that mean to you? He's hyper.
He's very active.
He's active. Does he sleep much? Does he eat much? Yeah, he probably eats a lot because he burns it off because he's so hyper, right? And so somebody that is hyperthyroid, that's really the definition of being hyper. Okay, if you are hyperthyroid, because the thyroid's job is to control your total body metabolism. Okay, so people that are hyperthyroid tend to be warmer. Instead of being 98.6, they might be 99.2. Okay, instead of eating 2,000 calories a day, they might eat 3,000 calories a day, but they still lose weight, or they certainly don't gain weight because their metabolism level is so fast, so high, that they're burning it all up, okay? They usually feel warm all the time. So here you got Brian, he's got his short sleeves up, he's got his sleeves rolled out, he's not warm, and I've got other people around here that have got on hoodies and sweaters and sweatshirts and so forth. Get the idea? People that are hypothyroid are just the opposite. They usually tend to be heavy. Why? Because they're not burning up as many calories. So even though they may not eat as much, they still gain weight. They're usually the ones that feel cold. Even though they're heavy and they've got all that extra insulation on, they still feel cold. Of all of the body functions, and we're talking, the cardiac heart rate is faster, their breathing rate is faster, their oxygen consumption is faster, their eating is faster, all this other stuff. There's one thing doesn't work that way. Anybody know what it is? There's one symptom that seems backwards. Well, it doesn't happen to us guys, but it happens to women. People that are hyperthyroid, you would think would have more periods than average, but they don't. People that are hyperthyroid have slow periods. They may go 6-8 weeks between periods. On the other hand, if they're hypothyroid, which you think would be slowed down and slower, they might have much more frequent periods. That's the one thing that seems backwards. Okay? So, the thyroid gland lives here in your neck. It consists of 2 lobes. The word thyroid means, in Latin, anybody know? It means shield. You know those guys that have those big shields look like that? Shield. 2 lobes on either side connected by a little isthmus. And what that means really is that the thyroid is shaped like this. Isthmus, 2 big lobes. Okay? Okay. The thyroid tissue, now we actually looked at thyroid tissue on the first day of 231. You probably don't remember it. But what we used it to look for was simple cuboidal epithelium. All of the thyroid follicles have simple cuboidal epithelium all the way around them, and in the middle, they have this kind of pink stuff that sometimes during the prep it got washed away. But that stuff that's in the middle of those follicles is thyroglobulin. It's actually thyroid hormone that's stored there and then can be mobilized rather quickly and be released. Okay, so when you look at thyroid follicles, you won't miss them once you've seen them. And you've seen them before, you just didn't really, maybe we didn't even tell you what they were early on. But this viscous colloid, this stuff that's in the middle of them, usually it's kind of pink on the standard stains. There's lots of capillaries. The thyroid is a very bloody organ. It has lots and lots of blood flowing to it. Thyroglobulin is the name for that globular protein that is out in the middle of these follicles. It is synthesized by the follicular cells. The cells that are around the edges are what manufactured that thyroglobulin, that it's stored out there in the middle. And remember that the amino acid tyrosine is very important in thyroglobulin. Now, thyroglobulin is actually made up of 2 different kinds of stuff, or broken down into 2 kinds of things. One's called T4, which is called tetraiodothyronine. Now think about that. tetra, 4 iodo iodine molecules. Thymine is the amino acid, the main amino acid that it's bound with. Okay? It's also, and that contains 4 iodide ions, and notice then there's also T3, which is triiodothyronine, and it contains 3 iodine ions. Now, just like the bones in your body contain most of your body's calcium, the thyroid contains most of your iodine. Okay, iodine is one of those things we just need tiny little bits of, but we do need some. And without iodine in our diet, even trace amounts, people used to develop goiters. And a goiter is where the thyroid is working overtime, but because it doesn't have any iodine to work with, it really can't make thyroid hormone. The thyroids get really big. Sometimes they got massive. In fact, there was a belt of middle America. You might think of it as the Rust Belt these days, but it's kind of like, Nebraska, Iowa, Missouri, Illinois, Indiana, into Kentucky. The water and the soils in that whole area of America had no iodine in it. And so lots of people that lived in that area got big goiters, and these things were huge. Even though they didn't show up as being really hyperthyroid or being hypothyroid, they just developed goiters. Goiter means enlarged thyroid. Okay? Now, 2 points. One more disease that the government totally cured. How did they totally cure that disease? They put iodine in the salt. That's right. So when you buy a box of Morton salt, it'll say iodized salt, which means it has about, 1/10,000th of it is iodine. It's an incredibly tiny amount, but it's all you need to not develop goiters. Goiters have pretty much been eliminated as a problem in America, totally. My other story on this, having been raised a surgeon, was that Theodore Kocher, K-O-C-H-E-R, Kocher, was the only surgeon that ever was given a Nobel Prize for inventing an operation. And he won the Nobel Prize for taking out thyroid glands. Okay? And he worked at the Cleveland Clinic in Cleveland, Ohio. Big multi-specialty people came from around the country to be operated on by Kocher. He has a bunch of clamps named after him that he used that we still use that to try to control the bleeding from the thyroid as he took them out. Well, I don't remember the year, but I want to say it was like 1921 that he won the Nobel Prize for it. And he wrote this article, and he said, here's how I do it. Here's all these drawings, and showed how he did the surgery, and that, and that, and that. The thing he didn't really talk much about was that almost a third of his patients died. They died post-op. Now, some of them died intra-op from bleeding to death because, as I said, the thyroid is a very, very bloody organ. But the other thing they died of, you know what the other thing they died of was? Remember those four little organs that live on the back of the thyroid gland? They're called the parathyroid glands. Nobody knew what they were. Nobody knew what they did. Nobody even knew they were there. Because as he would take out the thyroid gland, and because it was so big and funky looking, he would take out the parathyroids with it. And if you don't have parathyroids and you don't have parathyroid hormone, what does that do to you? Calcium. What happens to your calcium? Well, you can't regulate it, that's right, because you need parathyroid hormone to regulate it, but your calcium level goes through the bottom. No parathyroid hormone, no calcium. These people would go into tetany, muscles would start to twitch, and next thing you know, their heart would stop and they would die. in some ways, it's always been amazing to me that a guy would win the Nobel Prize for coming up with an operation that killed 1 out of every 3 people he did it on. Agree? Maybe not.
How did people survive then without that? How did they regulate their calcium levels?
Well, we didn't understand calcium metabolism back then. We certainly didn't understand parathormone. Usually what would happen is if their calcium dropped, sometimes one of their 4 parathyroids would sort of come back to life after a day or so and start working enough to bring their calcium level enough where they could survive. They also started learning early on that if they gave them shots of calcium, they could make the twitching and make the seizures and stuff go away. But they would do that for a number of days and then put them on lots of calcium by mouth, but still many of them died from the inability to regulate their calcium level without their parathyroids. Wow. I have to tell you another story. I got this call from my partners. You know, I retired back in 2001 from my surgery practice. And in my surgery practice, I had a big, in the waiting room, I had a big china cabinet, glass china cabinet. And I had always kind of been a collector. And I had a bunch of old surgical instruments in it. And the patients, when they would come in and sit in the waiting room, they would always see them, and they'd go look at them all. And then I got to where patients would bring me old surgical instruments. They would bring me old surgical books and all kinds of stuff, and I would just put them in the cabinet. Oh, when I left in 2001, I just walked away and left it. I said, here, you guys just leave this here for the patients to keep looking at, and they did. And I got a call from them the other day. All of the guys who were practicing when I was practicing are now retired. And they said, you want all this crap out here in this thing? And I said, yeah, I do. They boxed it up, and I just got it last night. And my daughter and I sat up last night going through it and looking at it and all these amazing instruments. And amazing old books, you know, books about surgery on the spleen when nobody really had surgery on the spleen, and if you did, it's probably going to kill you anyway. Back in the early 1900s, I'm just starting to read some of these old books again. They're just for the fun of it, really. They're so out of date. It is really incredible what we didn't know. You know, even in the 1970s, when I started practicing, what we didn't know that we know today. They say that medical knowledge is doubling every 7 years. Think about that. 7 years it doubles, 14 years it quadruples. It's amazing. Anyway, so here's this old lady whose picture they put up here for some unknown reason. And here is her thyroid gland right here. Notice that this is the thyroid cartilage. We'll come back to that when we get to respiratory. That's where your voice box lives, is right in there. So there's the thyroid cartilage, the cricoid cartilage, and then the tracheal cartilages, which you see illustrated there. So here's the thyroid gland. Here's the isthmus of it. This is the 2 big lobes. And notice that the thyroid gets blood supply from several different directions. It gets a middle. Here's the superior thyroid artery coming in here off of the carotid. There's a middle thyroid artery usually, which I don't see illustrated here. I guess there's at least a middle thyroid vein. And there's some inferior thyroid arteries that come in down here. So believe me, there's lots of blood supply to the thyroid gland. And then remember that the parathyroids are firmly attached to the back side of it. And they look the same. You have to kind of get down with your magnifying glasses on really close to see the difference between thyroid tissue and parathyroid tissue, because they pretty much look alike.
On children, because it's bigger on them, is that how far is? I mean, like, is it bigger on them?
It's about the same in children. You're thinking of the thymus gland.
Oh, okay.
The thymus is really big. It lives down here.
That's what shrinks.
That's what shrinks. Yes. Okay, so here's a slice of thyroid gland. It's these big follicles like this. They are simple cuboidal epithelium all the way around the sides here. And then there are these cells in between that are called the interstitial cells, and we call them C cells or interstitial cells, either one, because these cells are important because they make another hormone
Calcitonin.
called calcitonin. And you remember parathormone from the parathyroid gland makes calcium levels go up. Calcitonin made from these intrafollicular cells make calcitonin, which brings calcium levels down. And the two of them work kind of in tandem to keep our calcium levels just right. This is a thing that I would like you to look over. Think of this. What this is a diagram like this. You notice that there's blood vessel on the outside. This is a blood vessel. Here's the layer of follicular cells, one cell layer thick here. And then here's the middle of the follicle. The follicular cavity is illustrated up here by this pale yellow. So, this is the way it works, and I'm just going to leave it to you to get that. I think this is important. Know that the thyroglobulin out here in the middle contains both T3 and T4, and under the influence of TSH and thyroid hormone being released, that is mobilized and then put all the way back out here, put it out here into the bloodstream, and that's where you get T3 and T4. How many of you have had your thyroid level checked? And these days, it's a simple blood test, and on that one little tube of blood, you can test for T3 level, T4 level, and TSH level. Okay, so you can measure the TSH level. How much is their thyroid being stimulated to release thyroid hormone? Okay. With those three numbers, you can diagnose almost all thyroid problems. So, what's the feedback that goes on here? Well, let's think about it like this. The hypothalamus releases thyroid-releasing hormone. The thyroid-releasing hormone goes down here through the little portal system, goes down to the adenohypophysis. It affects the adenohypophysis, and it says, hey, release some thyroid-stimulating hormone, because that's the hormone that the anterior hypothalamus makes, the anterior pituitary makes. And so it releases TSH. Here it shows over here. The TSH then goes to the thyroid gland. The TSH tells the thyroid gland, hey, you've got all that T3 and T4 out in those follicles, mobilize it and release it. So the thyroid follicles start releasing the T3 and T4 out into the bloodstream. And then eventually this is going to feed back now as the T3 and T4 levels come up. That's going to feed back up here to the hypothalamus and say, hey, we got enough. Stop releasing this TRH, thyroid releasing hormone. Got it? It's a simple one-step, really, negative feedback system. Okay? So TSH, if you don't have any TSH, for example, if you don't have a pituitary gland, it's going to make your thyroid follicles become very inactive. They're not going to make any T3 or T4, and they're not going to mobilize any out into the bloodstream. Thyroid hormone, TSH, is bound to membrane receptors and activates these key enzymes. But just know that it's a stimulating hormone. It stimulates the thyroid to release thyroid hormone. What do the thyroid hormones do? Well, they circulate around in the bloodstream. They affect most all of the cells in the body. Thyroid hormone, a little tiny bit of thyroid hormone, can control every cell in your body and tell it kind of at what level it wants to be working at. If it wants to be hyper, work too hard, get too much thyroid hormone, too much T3, T4, hypo, too low. How does it work? Well, it goes into the cytoplasm, binds onto the mitochondria, goes into the nucleus, and it just makes everything go to town by causing more proteins to be synthesized and more stuff to happen. Here's a problem down here, and this is why every one of you who's ever been pregnant in this room, on one of your very first doctor visits to the doctor, had thyroid functions drawn on you. Because if you are hypothyroid as a pregnant mother, what's your baby going to be? It's going to be very hypothyroid. If the baby inside of you doesn't have thyroid hormone, they don't develop properly, and the thing that mainly doesn't develop is their brain, and they are called cretins. Now, that's called cretinism. Probably not the greatest name in this politically acceptable time, but that's what my sister used to always call me. You're such a cretin, Al. Anyway, no, cretins are retarded. They're very sad. It's a very sad thing. And it's all caused by women during their pregnancy not having enough thyroid hormone. Just one of the million reasons why prenatal care is so important, because it's so preventable. You just test them. They're hypothyroid, you give them thyroid pills to take while they're pregnant. No biggie. The thyroid gland kind of controls the calorogenic effect. This is which is what I wish I had, where you can get all the cells to burn up more energy, make more heat. This is why these people the hyperthyroid people are usually kind of warm, and they're hyper. It leads to an increase in cell metabolism.
Can you not just take a supplement? I mean,
Can you not just
well,
take
your common ones, I wish I had this, was get you to take supplement of thyroid hormone to increase your metabolic state.
It would be nice if it was that easy, but your body does adapt to it. And being hyperthyroidism is really not very healthy for you. It's kind of hard on your heart, and it's hard on your eyeballs, as I'll show you in just a minute. Being hyperthyroid is not a way to lose weight. Doctors used to think it was, and they would give every fat person thyroid pills. The fact is, if you take pills, then your own thyroid just goes to sleep. It doesn't make any. And you end up right back where you started. I'm going to let y'all read that later. I talked to you about the calcitonin. This is those inner, the cells in between the follicles. They make calcitonin. It helps regulate the concentration of calcium in the body fluids. In many ways, it's somewhat minor compared to parathormone. Parathormone is very powerful controller, but the calcitonin plays a distinct role, and they do battle back and forth to keep your calcium up or down to keep it normal. Hyperthyroidism could be described as where the term hyper comes from. This is my slide. And basically, all of your systems, all of your body systems go into overdrive except for one, and that's the menstrual cycle in females. Here's a lady with a goiter. You can see the big lump in her neck here. That can be caused by a lot of different things. But these days, we have a bunch of tests that can help us figure it out. First of all, we've got T3, T4, TSH levels. Then we've got ultrasound, which can measure and actually see exactly how big the thyroid is. And we also have nuclear medicine scans, which is where you take a little bit of radioactive iodine, tiny amount, and you give it to the patient in their arm. Circulates around through their body. Iodine is almost always picked up in your thyroid gland, and so you wait like 12 hours, I think, and then you bring them back and lay them under the scanner, and you scan for radioactive iodine, and it will usually give you a very clear-cut picture of the thyroid gland. If there's a lump in the thyroid, it'll show that. If there's a tumor in the thyroid, that'll usually be a cold area that's not really working right, so it doesn't show up as well. But between those tests, you can pretty well know exactly what's wrong with the thyroid. Most thyroid problems do not require surgery, just so you know. Most of them are, like for a goiter like this, usually most goiters, if you can be sure they're not cancer, you just treat them with thyroid pills, and this goiter just shrinks away. Most lumps in the thyroid will just go away. Most of the surgery we ever did on the thyroid gland was people that had a big lump in their thyroid, and we couldn't prove that it wasn't cancer. Sometimes these days we were just doing needle biopsies. You could actually just take a bunch of samples of the thyroid, and patients did pretty well with it, and then you could know exactly. Here's a thyroid goiter that I took out once upon a time, from a neck incision, transverse neck incision. This is what's called exophthalmos. This is what happens in people who are hyperthyroid. If you stay hyperthyroid, especially from this disease called Graves' disease, which is kind of an autoimmune kind of disease where the thyroid kind of overacts, these people get hyper, and you notice that in this picture you can see white down here below the eye, below the iris, and up here above the iris. If you look around the room, I think you'll see that most all of us, you can't see any white below the eye, and in most of us, you can't see any white above the eye. These patients actually are bug-eyed. Their eyes are actually bulging out due to an overgrowth of the tissue behind the eyeball caused by the hyperthyroidism. And this needs to be, these people need to really get treated. President George Bush, the senior George Bush, had Graves' disease. His wife, Barbara Bush, she also had it. They were both treated with radioactive iodine. You give them a shot of radioactive iodine, the iodine goes to their thyroid gland, it doesn't go anywhere else because nowhere else in your body do they want iodine, and it actually, because it's radioactive, it emits the radiation and it causes the thyroid to shrivel up and go away. You can have surgery and have most of your thyroid gland removed, but I-131 is really the way to go these days. It's so easy. Yeah.
What did you call it other than Graves' disease?
Exophthalmos. Exophthalmos. Ophthalmoscopy, you know? Ophthalmoscopes. Eye problems. Get it? And I don't know what the slide's in here for. I think I'll just leave it. This is a guy who was hypothyroid. Okay, this guy over here on the right, this is the person that's the slug that doesn't have enough thyroid, that's really slowed down. You notice he gained a lot of weight, he's a little chubby looking, that's just the way he is. Put him on some thyroid hormone pills, he looks like this in 3 months. Get his metabolism up to normal, he loses the weight, looks great. Okay, that's it for the thyroid gland. Let's talk about the parathyroid glands. They're these little tiny things that are found on the posterior. They are embedded in the posterior surface of the thyroid gland. They make PTH, parathyroid hormone, also called parathormone. The parathormone is made by the chief cells. The chief cells is easy to remember. That's just the chief kind of cell there is, there in the parathyroid gland. Parathyroid hormone is really made in response to low concentrations of calcium. So parathyroid hormone causes your calcium levels in your blood to go up. Now, if you go back to the early chapters when we were talking about bone, you ought to go look at that because you'll see that parathyroid hormone raises calcium levels, and it works in 3 ways, I believe. It causes the osteoclasts to eat up more bone and release that calcium out into the bloodstream. It works on the kidneys to keep your kidneys from peeing out so much calcium, so that raises your calcium level. And it works on your intestine, and it causes your intestine to absorb more calcium out of your diet. Okay? Here they are, looking at them from the back. They're little tiny things. I operated on parathyroid glands probably 6 times in my career. Usually we were operating for a tumor. One of these things had gotten a little crazy and was a parathyroid adenoma. But it's a benign cancer. It's not a cancer, it's a benign thing. But the patients would become very hyperparathyroid. So they were making way too much parathyroid hormone, and if you're making way too much parathyroid hormone, your calcium goes out the roof. If your calcium goes out the roof, in addition to sometimes getting a little wacky, mostly what you do is you make kidney stones. And so many of these patients would actually present to the doctor with a kidney stone. And then somebody asks, well, why did they get a kidney stone? Somebody orders a calcium level, and their calcium level is 13, which is supposed to be under 10. And so then they go through a workup. They get parathyroid hormone levels done, and you find out, oh yeah, they've got an abnormal growth in one of their parathyroid glands, and then we would go in and take it out. And it was great. It was very rewarding because the patients were, in the cases, if the cases are correctly screened and you have the right patients, which I was lucky to say was the case every time, the patient is cured. When you walk out of the operating room, their calcium level is down to normal by the time you get into the recovery room. It's really great. You forget how fast some of these hormones work sometimes. So this is a microscopic slide of the parathyroid gland, and you guys all want to look at them. These are the cheap cells, which are the ones that make the parathormone. There's some other cells called oxyphil cells that are seen out in there as well. A lot of blood vessels running through the parathyroids, just like there's a lot of blood vessels running through the thyroid gland. 4 effects of PTH. I gave you 3 of them just now. One of them is it stimulates the osteoclasts to eat up more calcium, eat up more bone, right? And put that calcium out into the bloodstream, accelerating the mineral turnover. It also inhibits osteoblasts. What do osteoblasts do? They make bone. So osteoblasts actually suck the calcium out of the bloodstream, turn it into bone, and that lowers the blood calcium level, okay? But this is just the opposite. It inhibits the osteoblasts so that they don't do that and leaves more calcium in the bloodstream. So there's the 4. Stimulates osteoclasts, inhibits osteoblasts, enhances reabsorption of calcium at the kidneys, which means more calcium goes out in your urine. And it also stimulates the formation of calcitriol at the kidneys, and that enhances your calcium and phosphorus absorption by the digestive tract. Now, as a flash out of the past, where have you heard about calcitriol before?
Vitamin D production.
Vitamin D, that's right. Remember, vitamin D is why you need to go out in the sun, because the vitamin D is in your skin, and it converts the vitamin D into calcitriol. Calcitriol then goes to your intestines. After being it gets converted in your kidneys into calcitriol, which then works to make you absorb more calcium. So remember, these were the kids who never got vitamin D and never got out in the sun. They had rickets. That's right, the bow legs, because of the kidney problem here, because they didn't have enough calcium. Oh yeah, now I remember that. This is all going to fit together by the time you get to the end of this. Believe me. Okay. This is a kind of a nice little regulation thing about the calcium regulation that I think you should understand. I think there's an essay question about how does calcium get controlled. That's part of it right there. Okay. Next glands let's talk about are the adrenal glands. We usually call them the suprarenal glands now, which just means on top of the kidneys. They lie along the superior border of each kidney. They have really 4 layers to them. They have 3 layers in the cortex of the adrenal gland, and then in the middle of the adrenal gland, you'll see the medulla. And you remember the medulla because we've already talked about the medulla quite a bit. And remember, the medulla is the thing that makes adrenaline, right? What's adrenaline really? Epinephrine and norepinephrine. Right? Okay, so I'll draw you a little picture here of the adrenal gland. Let's just say it kind of looks like that. And in the middle of it out here is the medulla. And that means that the rest of it is called the cortex. Okay? Medulla makes epi and norepi. And remember from that slide I showed you a few minutes ago, there's actually neural nerves that carry signals from the brain down to the medulla here to cause it to release epi and norepi in the fight or flight reaction. Okay, so the medulla is very important in the fight or flight thing. If you don't believe me, go back and read in the chapter on the autonomic nervous system where it mentions it back there too. Okay, now there are 3 layers to the adrenal cortex, and let's talk about those. Here they are right here. There is the zona glomerulosa, zona fasciculata, and zona reticularis. Now, my problem is I never can remember which one of those 3 layers is on the inside and which one's on the outside. But I will tell you that they're like right here. 1, 2, 3. I'll come up with names for them as we go through them here. I don't remember whether it's 3, 2, 1 or 1, 2, 3. All right. The zona glomerulosa. Oh, now we know. Zona glomerulosa is the outside layer. And so zona glomerulosa produces mineralocorticoid. What does that mean? Mineralocorticoids. Well, those are cortical steroids. Cortical means they're coming from the cortex of the medulla, right? And they're mineralocorticoids. Well, minerals are things like, I'll just say, they're things mostly like sodium and chloride, okay? So, salt. The hormones that are manufactured in the zona glomerulosa are hormones that cause us to control the amount of salt that we have in our body. Very important that we have the right amount. The most important mineralocorticoid is called aldosterone. Okay? Aldosterone. Now, when I was growing up, they always called it aldosterone. So you can say it however you want, as long as you spell it right. What does aldo do? Aldosterone causes you to hold on to salt. Okay? So, if you have a drop in your blood pressure for some reason, or if you're getting a little dehydrated because you've been running too long and sweating too much, the aldo will make you hold on to extra water and hold on to extra salt. In other words, it will help regulate your body fluid levels, which we're going to also come back to in the future. The zona fasciculata is the one in the middle. It produces, so this is fasciculata, and it controls the sugar, basically. And it controls, basically, it's cortisone and cortisol. People that have too much of this, too much cortisol, develop a problem which is called Cushing's disease. Cushing's means too much cortisol. You might also think of it as hyperadrenalism. In other words, there's just too much. You're making too much steroid. You're making too much cortisone. It causes you not to fight infections very well. Usually, patients with hypercortisol get big. They gain a lot of weight. They get what's called moon faces. Their face looks big and round just from the deposits of fat in their face, and so forth. Dr. Harvey Cushing here, was a neurosurgeon at the Johns Hopkins University in Baltimore, Maryland, one of the premier hospitals in America. And he invented this disease, or at least he described it for the first time. He saw a number of patients referred to him that were hypercortisolemic or had too much cortisone. They would be sent to him because they had pituitary tumors that was making too much ACTH, which was then stimulating to make too much, and they would get all those findings that we just talked about. So he was doing brain surgery on them, on their pituitaries, trying to fix it, and that's how the name got attached to him, Harvey Cushing. There's another neurosurgeon that went through Johns Hopkins that studied there and practiced there. And I'm about convinced he's the craziest guy on the face of the earth. But he was in the Republican discussion last night. Ben Carson. Yeah. He was a brain surgeon. He was the head of pediatric neurosurgery at Johns Hopkins University in the footsteps of Harvey Cushing. Huh?
He is crazy.
Yeah, he is crazy. At least the things he says are crazy. Maybe he's not crazy, but he sure talks like he's crazy. Anyway. Whenever people have too much cortisone, they also make too much sugar. Their blood sugars go up. Cortisone is almost the opposite of insulin. Insulin brings your blood sugar down. Cortisone brings it up. Many of you have probably had cortisone shots before in a joint. Or cortisone cream on your skin if you had a bad rash of some type. It basically is an anti-inflammatory medicine, and it inhibits the white cells in their action. So it kind of suppresses your immune system. So a lot of people that are taking asthma, a lot of the inhalers are based on cortisone. In fact, if you look at the names of them, some of them have cort in it, C-O-R-T, in the name. The final layer is the zona reticularis. Zona reticularis is the one that produces androgens. Androgens are hormones, sex hormones. What's the main androgen? Main androgen is testosterone. Just know that in the early years of my training, when we had a lady that had breast cancer, we knew that breast cancer was stimulated by estrogens, okay? So if a lady had breast cancer, the first thing in the world you want to do is get her off of all of her estrogens. No birth control pills, no HRT, no hormone replacement therapy, nothing like that. Because we knew that by giving her estrogen, that would stimulate the cancer cells, the breast cancer cells, to grow. In fact, what we learned was that the adrenal gland, although it says here androgens, it's also making some estrogens as well. And so ladies that had recurrent breast cancer, so you'd operate on them, remove their breast, remove the lymph nodes, radiate them, and then it came back. You'd then reoperate on them and take out their adrenal glands and take their ovaries out at the same time, because both of those organs made some estrogen. If you could get all the estrogen out of them, they would do better, and they lived longer, and it did work. But then someone came along and invented a pill that they take once a day that has almost no side effects. That is an anti-estrogen pill. The name is tamoxifen. Anybody know anybody on tamoxifen? It's a really common drug in cancer treatments these days. But tamoxifen basically just goes around and finds any little bits of estrogen or androgen in your body and just eats it up. The ladies hate it at first because they have incredible hot flashes. But it works really well. It really extends life. Here's where the suprarenal glands live. They look like these yellow things. We used to always call them, they said they look like a tipped tricorner cap. Does that look like a tipped tricorner cap to you? Anyway, 1 and 2. Once again, the adrenal glands have amazing blood supply. Lots of blood vessels go to it. For example, they get blood off of the renal artery. Here's the renal artery that's going into the kidney. It's a big, huge artery. Carries 1/4 of all your blood flow, goes to your kidneys. Here's a branch off of it going to the adrenal called the inferior, right inferior suprarenal artery. Then directly off the aorta here in the abdomen, there's the middle suprarenal artery. And then coming off of the phrenic branches, these are the phrenic arteries that go up and service the diaphragm, carry blood to the diaphragm. You have the right superior and left superior suprarenal arteries up there. One of the greatest experiences of my life, probably one of the cases that I remember the longest and still do. I think the guy's still alive. He came in with a adenocarcinoma of his left adrenal gland. And adrenal carcinoma, adrenal cancer is very rare. And when it does occur, it's almost universally fatal. His was pretty big, and he was a dentist in our town out there in the Dalles. And we sat down and talked one day, and I said, well, you know what, it's probably crazy to try to take this thing out because I may end up having to take out your colon and your stomach and your spleen and your pancreas as well because they all kind of live up in here. And he says, well, let's just give it a shot and see what happens. And what we did was we took out his kidney, his adrenal, his stomach, his spleen, distal end of his pancreas, and the left part of his colon up here. A piece of colon out, put it all back together. And the guy's still alive 15 years later. I haven't seen him in the last year or two, but he still sends me a Christmas card every year, which is kind of nice.
How many hours did it take?
Well, about 3. I'm glad we went ahead and did it. So anyway, here's what the adrenal gland looks like under the microscope. These are the 3 layers: reticularis, zona, fasciculata, and glomerulosa. On the cap, this is the capsule. This is the outside of it. So basically, you'd have to take this little section through right here. You see, up at the very top is a piece of medulla. Would be right up in there. Now, the one thing I will promise you is that I will not have you try to identify the regions of the adrenal gland under the microscope, okay? Because it's just too hard to make it look perfect, because it has to look perfect, because you can see the difference between this and this and this is not all that great. But believe me, I have very good photographs of it, and on the photographs, I feel very comfortable asking you what layer this is and what layer that is, okay? The medulla in the middle, 2 kinds of cells. One makes epinephrine and one makes norepinephrine. I think that's enough said about that. Let's just quit there. Here's a patient with a adrenal tumor right here. I think this is the tumor. Yeah, this is the tumor right here. This is the kidney. This is a CAT scan slice, not a very good one. Here's the backbone, here's the vertebrae, the body of the vertebrae. The spinal cord would be running right through there. There's the posterior elements of the spine, posterior spine. Liver up here, air. This is gastrographin. Now white is you have to swallow some gastrographin, which is a watery, like barium, except it's not barium. doesn't allow the X-rays to penetrate through it, so it shows up as white. And you know that because it's white, that's in the stomach because you just gave it to the patient to have them drink maybe 10 minutes before they took the scan. Spleen. I don't see spleen in this picture. Here's the two abdominal muscles. What do you call those muscles right there? That one and that one? Rectus abdominis, right? Pineal gland, you don't have to look at this under the microscope from my point of view. Just know that the pineal gland lives up in the brain. It makes the hormone melatonin, and melatonin plays a very important role in sleep. Yeah. It also inhibits reproductive functions. Maybe that's what the problem is. Maybe I better quit using so much of that. It helps set your circadian rhythms. That's that 24-hour rhythm thing that makes you wake up in the morning and go to sleep at night. Let's talk about the pancreas quickly. The pancreas, we will come back to the pancreas in great detail when we get to the digestive system, because most of what the pancreas does is help you digest your food. However, the pancreas contains both exocrine and endocrine cells. In fact, it contains 99% exocrine cells and 1% endocrine cells, okay? So exocrine means
Excretes through a duct.
it excretes into a duct, that's right, and the pancreatic duct collects up all of these secretions and dumps them into the duodenum, the first part of the small intestine, to help you digest your food. The endocrine cells of the pancreas are found scattered throughout the pancreas in little islets. And it's a Jeopardy question about every month. Where in the world do you find the islets of Langerhans? And the answer is the pancreas. Okay? So, the endocrine pancreas, the only parts of the pancreas that make hormones are these pancreatic islets, or islets of Langerhans. Once again, we're trying to get away from using people's names like Dr. Langerhans, but it's still around. It's so widely used that everybody knows it. It contains 4 different kinds of cells, but I'll be honest with you, I just want you to know 2 of them. I want you to know that it has alpha cells and beta cells. Alpha cells make glucagon. Glucagon is a hormone that raises your blood sugar, keeps you from getting hypoglycemic. Beta cells make insulin. Insulin brings your blood sugar down. And the defect in diabetes is not enough insulin. Okay? We'll talk more about that. There are 2 others, delta cells, that make growth hormone. It's kind of a sort of like growth hormone. And there's some other cells that make this thing called pancreatic polypeptide, which is a protein. I'm not really quite sure what it does. But I would just remember that the islets have alpha cells and beta cells that produce alpha produces glucagon, which raises blood sugar. Beta cells make insulin, which lowers blood sugar. And you know, a lot of diabetics take insulin as a shot every day in order to keep their blood sugar under control. So here's what it looks like. The pancreas has got a head, a body, or a neck, a body, and a tail. The spleen lives right over here by the tail. Now, Steve Jobs, I don't know if you've seen the movie. I haven't seen the movie yet, but I know that Steve Jobs died of pancreatic cancer. He died of a benign kind of cancer. It wasn't plain old pancreatic cancer. It was very curable. He just decided not to have surgery on it until it had just gotten crazy and gotten huge. And but most pancreatic cancers occur here in the head. Now, that's probably not a true statement. The reason that we diagnose most pancreatic cancers is because they live over here, and as they get bigger and bigger, they block off this tube here called the common bile duct, which comes from the liver. And when that duct gets blocked off, what happens to you?
You have too much ammonia in here?
Not ammonia.
Too much of that green stuff that's coming down through that bile duct called bile makes you turn yellow. You become jaundiced. And indeed, that's what happened to Steve Jobs at the end. He got jaundice from blockage of his bile duct. Indeed, that was the only way we could ever diagnose pancreatic cancer, was when they blocked off their bile duct, they turned yellow, then we thought, oh, well, maybe they got pancreatic cancer. Because we had no good imaging techniques to identify the pancreas. Until CAT scans got really good, you couldn't really see the pancreas very well. It lives right in the back. But anyway, so here's the exocrine part. You see the ducts, the duct connects all the way down through here and empties into the small intestine. The first part of the small intestine is called the duodenum. The stomach lives right up here, just right above that. So we rarely would do surgery on the pancreas. You didn't ever want to do surgery on the pancreas because think about it. What this thing does is it makes all these digestive enzymes that allow you to break down your fats, allow you to break down your proteins, allow you to even break down carbohydrates with all this juice that comes out here every day. And indeed, we make about 1.5 liters of pancreatic juice a day. So it's quite a lot of fluid that's dumping in here to mix with your food. Well, think what happens when that juice gets loose in your body. So if you cut the pancreas in half here, then you had to sew this duct back to the bowel down here somewhere and be sure it didn't leak a drop, because if it did, what would happen? Well, it would just start digesting itself. So the places where you sewed it together, it would digest and everything would just kind of fall apart and turn to soup. So pancreas is not something you ever really wanted to operate on. When you did, you had to be incredibly careful to sew the duct very, very carefully into a loop of bowel so that the juice would empty into the bowel and not out into the belly. Here's an islet of Langerhans. They're very distinctive. When you look at pancreas, you won't miss them. They stick out like a sore thumb. They're just, scattered around. Please do not think that you have to be able to say, oh yeah, this is an alpha cell, and oh yeah, that's a beta cell. Just know it's an islet of Langerhans. That's good enough. And know that there are alpha and beta cells in there. Let's talk about blood sugar levels for just a minute, because our blood sugar control is very important to all of us. When the blood sugar level rises, then, assuming we're not diabetic, we make insulin, and that causes the glucose level to come back down to stay normal. If the blood sugar drops too low, then our pancreas releases glucagon. Glucagon raises the blood sugar back up. Okay? There's another one of those nice little slides that you ought to take a good look at. Talks about how to control blood sugar. I think there's an essay question on that, isn't there? I don't know. Maybe that was another year. Another time. So, insulin is a peptide hormone. It's one of the it's saved the lives of every diabetic in the world. Most diabetics would be dead in 3 days if they don't have insulin. The blood sugar just goes crazy. Let me stop for just a second and say there's 2 basic types of diabetes. First type is type 1. We used to call that juvenile onset diabetes. And what would happen in juvenile onset diabetes, and I saw this happen maybe 5 times in my career, is you got a teenage kid or a kid that's 8 or 10 years old, and suddenly they get really sick one day, and you think they've got the flu or they've got a cold or something, and they sort of start to get over it, and next thing you know, they're in coma and they can't talk, and they get run up to the emergency room, and somebody draws a blood sugar, and their blood sugar is 1,200 or 1,600. Normal is less than 100. And immediately the diagnosis of diabetes is made. What has happened is they developed a virus of some type that destroyed all of their islets of Langerhans in 1 weekend. The virus went through their pancreas and killed off all of their islets. They can now make 0 insulin. And so for every day of their life, they will need to receive insulin or their sugar will go out the ceiling. Okay? And there's no pills that those kids can take or anything. It's insulin or nothing. It's shots or nothing. Now a lot of them are getting pumps now that get buried under their skin. A lot of them they're able to prick their finger and check their blood sugar a bunch of times a day, and then they turn it up or turn it down. They're pumped. And so it pumps a little more or a little bit less. It's really got kind of sophisticated. The newest ones actually have a sensor in there that senses their blood glucose every 5 minutes and decides how much insulin to inject.
It also texts to their smartphone, their numbers.
There you go.
So if it gets too low and they don't know they're going into a diabetic coma,
Right.
it'll text alerts to other people.
Good point.
So then post on Facebook.
Didn't they want to go on Facebook? Yeah. And where else do you want your blood sugar if it's not on Facebook? All right, so that's type 1 diabetes. Type 2 diabetes, which is the thing that's sweeping our country right now because so many of us are heavy, is that we're still making enough insulin, but the leptin, which is fat, makes the fat of our body makes another hormone called leptin, which is kind of an anti-insulin. And so even though you've got enough insulin, in fact, you may have too much insulin, it doesn't work very well because it's being opposed by this leptin, called insulin resistance. And that creates what's called diabetes type 2. And type 2 diabetics may end up on insulin someday, but most of them can be managed with pills. The pills stimulate the pancreas to make more insulin. And you make enough, and it overcomes the resistance, and it works pretty good and controls blood sugars. So I'll just leave it at that. Yeah.
What about gestational diabetes?
It's like type 2. You're still making enough insulin. It's just it's not working well, and the stress of the baby and all the nutritional needs that you and the baby have can make ladies turn into diabetics until they deliver. And usually once they deliver, then they revert back to normal.
Are they higher risk for developing type 2 later?
I'm sure that's true. The babies are higher risk by far. But babies of gestational diabetics can get huge, and they can get 13 pounds. And, yowzers. So you need to know a little bit about glucose. Insulin. You need to know about glucagon, and I think this is the end of the lecture. Just know that there are many other organ systems that release a lot of hormones into our blood. The intestines, we will talk about extensively the hormones that your intestines release when we get to the digestive system. The kidneys make hormones that we'll learn about when we get to the urinary system. The heart makes some, the thymus, and the reproductive system makes a bunch more. Tell me we got 35 more slides? Yeah. I think I've said all I wanted to say about these things. I'm just skipping over these because we don't really cover the rest of these hormones in this chapter. Leptin, I've already mentioned, that's the one made from fat. A couple other words you ought to know. An antagonistic hormone has opposing effects. A synergistic hormone has additive effects. Two hormones that work in the same direction, you could say, are synergistic. Two hormones that work in opposite directions, you could say, are antagonistic. Permissive effects, one hormone is necessary for another hormone to work. Integrative effects, hormones produce different and complementary results. I would just, don't worry about those terms. Oh, here's one last thing I do want you to know. There are several hormones, a group of hormones that are very important for growth, okay? And growth is a very long-term thing, right? We're all still growing, right? Maybe we've all closed our epiphyses and we've quit getting taller, but we're still growing. And so sure enough, growth hormones, thyroid hormones, insulin, PTH, which controls our bones, remember, calcitriol, which works on our bones, and the reproductive hormones, especially testosterone. Testosterone is the other major PED, performance-enhancing drug. Take testosterone shots, and you can turn into, a defensive lineman for the Green Bay Packers if you take enough of it in about 6 months. And if anybody thinks that pro football players don't take hormones, they are crazy. Those guys are all taking them. You can bet they are. How else did they get that big? Their mothers didn't feed them that well. Protein, there you go. He said it's protein. Let me talk real quick about the general adaptation syndrome. The book goes into great length about this. It's just basically the stress response. How does our body respond to stress? Okay? Now we said the first thing we do is we do the fight or flight deal, right? We crank everything up as much as we could. And the resistance phase, we start burning up our muscles. We start burning up everything we can in order to fight the problem, whatever it might be. And then there's this exhaustion phase. And I read this chapter a couple of times long ago. And the thing I always remember was it never did really tell you what this exhaustion phase means. Well, I suggest you read the pages. Don't worry about it at great length. But just know that the exhaustion phase is when you die. Okay? If you get to the point where, let's just say you have a pneumonia or an infection, and your body does everything it can, fight or flight. It pumps up its heart rate, it throws out all the white cells, it does everything it can to fight off that pneumonia, and you get over it, that's great. And then if you don't, and the pneumonia keeps wearing on you, and you start throwing everything you've got left at it, all your body systems, then you're probably going to go into this exhaustion phase, which means you're on a downward trip towards the grave. The exhaustion phase, you often hear, they were in multiple organ failure. Right? You heard that term? That means the patient is going into heart failure, and kidney failure, and brain failure. They're probably not thinking very good, and everything is failing. And that's what we're talking about here when we talk about the exhaustion phase. So in the alarm phase, it's fight or flight, general sympathetic activation. The medulla is forced to release all the epinephrine and norepinephrine it can. Then it sort of cranks in and starts going for the long run. You start releasing growth hormone, which helps you fight infections. You start releasing all these glucocorticoids that help you fight and suppress an infection. Glucagon, all the mineralocorticoids, you're hanging on to all the fluids you can, all the salt and so forth. And if that doesn't do it, you're going to die. And that's, you exhaust your lipids, you use up your fats, you lose up a lot of the functional parts of your heart muscle starts to give way. You start being unable to produce any more glucocorticoids. You can't control your electrolytes, and you go down the hose and die. The last thing I would say about aging is everything goes to hell when you get old. Growth hormone goes down, reproductive hormone goes down. I don't think I have to say that to any of you guys even. But just know that the endocrine system works on all of your organs, your skin. It makes you look older. You've seen Cindy Crawford on TV, right? It takes all that wonderful stuff, tries to sell it to you. Anyway. So it affects all of the systems, and you need all of the systems to really live a decent life. That is all.
I think you lose 1% of your organs capability, 1% a year after 30.
That sounds right. Women lose a lot more than like 3% of their bone a year. Okay, so we will go to lab. We'll have a little quiz in lab, and we'll have maybe we can do a little bit of review, or at least I'll answer questions on Tuesday in preparation for test 2 on Thursday. Test 2 will cover endocrine and what was before endocrine? What? Yeah, the special senses. Eye, ear, nose, throat. Okay.